Duchenne muscular dystrophy is a rare disease typically found in young boys that leads to the progressive degeneration of muscle cells due to the absence of the dystrophin protein. Living with Duchenne muscular dystrophy is a hard life that results in boys needing a wheelchair, having limited use of their arms, ventilation to aid in breathing, and eventually death at an early age due to cardiac and lung failure. There are a lot of therapies that must be done for those with DMD to try and increase their quality of life. Therapies include corticosteroids to preserve muscle strength, maintaining good diet and exercise, and providing high blood pressure medication to preserve cardiac function. DMD patients must visit a wide array of specialists since this disease affects many bodily functions. Today we're excited to introduce you to Ms. Anna Rivero, a pediatric occupational therapist who has worked closely with a few DMD patients. As an occupational therapist, she works with an entire team of people to help DMD patients and their families in many aspects of their lives. She graciously speaks with us about her perspectives and interactions with boys living with this difficult disease and gives us insight into how occupational therapy is used to relieve the symptoms of DMD.
My name is Anna Rivero, and I'm an occupational therapist, pediatrics. I do adults as well, but I'm mostly pediatrics.
Okay.
Yeah.
And where are we right now?
We're in Mills Peninsula Medical Center in San Mateo.
So just to start off, what is occupational therapy and how's it different from other forms of therapy like physical therapy or something like that?
This occupational therapy is a form of therapy that focuses on enhancing function. Specifically for us, we look at how in the pediatric realm, we'll look at fine motor, sensory processing, visual processing, development, specifically for pediatrics. And it's different from physical therapy in the sense that physical therapy focuses on the body, mechanics, and we'll usually do development as well, but they'll do the gross motor activities. So for example, like the walking, or if a child's not crawling, they'll focus on those things. And of course, it overlaps. It's never cut and dry.
So how long have you been working as an OT?
I've been working here at Mills for 12 years. Before that, I was at another group for about 4 years. So.
And then what is your experience working with patients with Duchenne muscular dystrophy?
My experience has been unique. I haven't had a multitude of patients, but the ones I've had, one has been unique in the fact that he was a rare early onset of Duchenne's, pretty much at the age of 12 months. So that has given me another perspective on the common onset, which is usually 7 to 10. And I've also worked with patients who were onset was 7 to 10.
And then do you usually work with them up until a certain age or like?
In this case here, I did work with them up until the early teens. Most of the time, because we're an outpatient clinic, we don't always get Duchenne's for a long time. We're often the ones that diagnose or like see the onset, but they usually will go to CCS, which is California Children's Services. If there's an overflow, we see them. So it's sometimes a process of the healthcare system that either keeps them here or not. But in my case, I was able to see the two patients that I had for a span of anywhere from, well, one for 12 years and the other for up to 7 years.
Okay. And then from your experience, how has DMD kind of affected the patient and their families, and how do you see that they like cope with the disease?
Because it's a progressive disease, it can be pretty difficult for everyone all around. You know, I can say specifically for my one patient whose diagnosis was early at 12 months, you know, seeing a child who's not meeting their milestones and not getting better and just consistently, you know, inching along but not really getting better, it's a tremendous burden on the family for sure. For the kids that I've had, they're pretty resilient. So even though they're having a hard time, the kids usually, they actually work through it a little bit. The two children I had were very into boy stuff, playing baseball, you know, wanting to roughhouse and wanting to be physical. So they were willing to play anything we gave them, and so they showed their resilience in that way. As they got older, when they were able to kind of express more, they would express their fears, their questions, their concerns, you know, their curiosities about what was going on, and so we're also there for that as well. Families are the same thing. Again, it's a progressive disease, so as the child has more needs, we will start to talk about equipment, safety in the home, because their physical ability decreases on all parts. As an OT, I focus on like fine motor, visual motor, sensory processing, which is often comes into play when they start to lose function. We address those issues, and then of course, again for OT, for self-care function, we address, help families on like how to modify activities or look at different equipment that might be needed. Look at their home and what might need to change in the home, and again over years, there may have more and more needs. As the child loses function, then the parent has to step in more. So we often will train whoever's involved will train who needs to be trained. The good thing about that is that if there's more than one caregiver, they can just come right in. We have that luxury to say, it doesn't have to be one specific person. We can say if they have a nanny, if they have another caregiver, a parent, or everyone can get trained on what's needed for the child. Just to let you know that the other process for having children with muscular dystrophy is that they will often have a social worker that we work with.
Okay.
They will also often have people in the school district that we're also working with for school issues, or school equipment, seating, whatever they need, right? Wheelchair. And so there's often a team that we're working with the doctors.
So it's never just you.
It's never just me.
You're always communicating with other healthcare providers.
Correct.
And
Yeah,
not just providers, just people who are interacting with the child and stuff like that. Right?
exactly. And there's often a team with children.
Okay. What are the functional abilities of these patients, like before you saw, or like coming in when they first started therapy, and then what kind of specific things did they have trouble with?
So for the child that I worked with who had like the typical onset, so his was around starting to show the Gower sign at about 7, which is where they are unable to get up off the floor on their own, and they use a specific sign of walking their hands up their thighs till they can get up. So he started showing those signs at about 7. So before he came in, when we got him, he was about 5 because he was showing some gross motor development issues with balance and coordination. So he actually went to physical therapy first.
Okay.
And then, once in physical therapy, he started showing some signs of visual motor issues, such as copying or coordination with his fine motor skills, like using a pencil, right? So at that age, they're doing more writing now, doing more mazes and things like that. So they're using a tool more. So he started to show some coordination issues with that as well. And that's when he came to me. And from there, it just having both disciplines on board at the same time, we were able to really see everything across the board and work as a team to help him. But then that's when he was diagnosed. So we were seeing a lot of different things, and kind of red flags were coming up, and we assisted the parents in getting more information and getting tested, and then he was diagnosed. And you can test by blood work.
Oh, okay, just to see it, yeah, and then the biopsies and stuff.
Yes, and the biopsies, right.
When you say, and then, so you've been working with providers and stuff like that. Is there other specific therapies that come to mind now that like if you were presented with a patient, with a DMD patient, like there are just specific things that you want to look for, specific exercises or things that you have them do at home or something like that? And how is it different? How is like their specific treatment options, or like their, I don't know what the word is, but like things you do with them? How is it different from other patients?
The biggest thing from other patients is that because their disease is progressive, we actually go from, we'll obviously get their baseline, and what we'll have to do is you have to learn how to grade from their baseline down. So with most therapies, with any kind of therapy, you find a baseline and you grade up to progress them. Because it's the opposite. We have to look at it as not a negative thing for them. It's actually a positive thing, because we're gonna grade activities or situations, for example, well, their needs are for equipment. That's actually gonna be a positive for them, because it's gonna keep as much function as possible. So in terms of other disciplines, at least for OT, for the particular patient that had his onset as typical. I worked a lot on posturing.
Okay.
So keeping him in a good posture so he could use his hands.
Mm-hmm.
Keeping him with a good setup that wasn't so overwhelming so he could pay attention. And that's very different from, say, what PT would do with him.
Mm-hmm.
They'd be working on his core,
Yeah.
or doing some, leg exercise, for example. We mentioned exercises.
Mm-hmm.
Or with, I don't believe he needed speech, and he may not need speech, but I think for him too, he had a behavioral specialist, because that was another team member that was brought on later. So oftentimes they'll need behavioral specialists, or sometimes family therapy. But in terms of OT specifically, I was working a lot on just keeping up strength.
Okay. Yeah. And
But
more maintaining rather than building, right?
correct. Okay. Maintaining than building. If we could work on strength, because that's another area that's a fine line, and that's where your clinical reasoning and all of your professional skills come in. Maintaining what they have and not pushing them where it's going to be negative for them.
Yeah.
But
did you have any worries when you were working with them? Like, because that's one of the things, like, you don't want to strength test or strength exercise is just
right.
no, because it ends up hurting the muscle.
It can hurt the muscle more.
So did you ever have to hold yourself back when you're trying these different things?
I did with my patient who was an early onset, because he was such a special case. We were really had to be careful with him, and so really the therapy was around listening to him too, really recording and keeping track of his fatigue level. We do that for everyone, but we went even really a step further with him because of his early onset, and we didn't know what the disease process how different it would be for that particular patient. So yeah, of course, we paid extra attention. We recorded more with the fatigue level. Really had to do lots of parent education, because that was the other area that parents wanted to let more is not better sometimes with therapy. So we had to do lots of education with the parents and the caregivers to make sure that we weren't pushing them where they were going to be a negative thing for them.
And then, so towards the end of when you were working with them, or I guess the time you have with them, were there specific things that you kind of see the improvement in, or things like that? And how do you think this kind of affected the patient, both them themselves and their families, like physically or mentally?
Towards the end, as they got older, specifically for my patient who had the early onset, he actually just kind of rewind a little bit. In the last 2 years, he actually started to have more falls, and he had around 3 fractures. So we really had to change our therapy. Actually started to be around bringing him back after a fall or after a fracture. And so
more case by case rather than just the overall growth of them, right?
For sure. Case by case. So we had to do a lot of more extra safety training again. We had to do, again, going back to bring to self-care functioning during the injury and then after. Luckily, he did get better. He did recover from his falls, and he didn't have any more complications. But that doesn't always happen for everybody. And so by the end of his care, we were actually working on tons of safety in the home and in school. Safety training, and then we were doing a lot more equipment, analysis of what's going to help him to stay safe. For him, it kind of came down to transfers and a wheelchair for his equipment, because he was also losing function in his upper body. We had to modify what we were giving him in terms of even eating utensils, So that's kind of where it was ending, and then he left CCS. Oh, okay. It was actually recently, so that was kind of a sad thing for us. But he had to change because of this change in the care, the resources, right?
So there is no so that means when I ask you these questions, there is no blueprint for any of these patients, because you never know what some of the stuff that happens, right?
That's correct.
And every body's different, right?
Correct.
Okay.
And you never know what. Because a lot of the kids, they're living longer and longer. So even as teenagers, they get bigger, but they're losing function. So a lot of times there's more and more surgeries involved later because of scoliosis and other complications as they get bigger. gravity's not their friend. So there's other things that start to happen as they get older. So I don't, that's not a positive thing that we look at, but that's another area that has to be addressed.
Yeah, so be kind of conscious of that when you're working with them and stuff.
Totally, yeah.
Okay. So I guess just to encompass everything, why is occupational therapy like specifically important for these patients, and what is the impact what is the impact of the therapy on these patients specifically?
So occupational therapy is important for the DMD community because we do see them oftentimes early, which is good, but we start to work on things like not only their self-care, it's all functional skills, but everything from self-care, the fine motor, visual motor, a lot of times sensory processing, because they do have sensory issues. As the system changes, they'll start to process, like even touch different. So we do a lot of sensory work with them. We work with the families to help, and we also are a huge part of their equipment analysis. So we have to be part of that team for not only the physical therapy part, but for all the other parts I just mentioned. Anything from eating, from dressing, from the functional transfers, from areas in school. We're often part of that team for positioning in school or things that'll help them, tips and suggestions on helping them learn better. We help the teachers a lot. So we have a huge part in a lot of areas of the patient's life, basically, which is good, I think. As one of the team, we're the ones who get to be with them. We get to spend time with them. We get to know them. We get to really ask them, what do you need? What do you think is going to be helpful for you? And to me, that's one of the most rewarding parts. Even though it's difficult, knowing that you're helping someone in that way is good.
Would you say that you as like an OT are you guys like the only ones that really encompass all these different sectors of their life? Is it like if they're sent off to a PT, do they just kind of do what they gotta do and then send them back or something like that to work with everybody else?
Right.
Yeah.
I think physical, at least in our clinic, the physical therapist is very involved as well. Part of being a pediatric therapist, I think we have that kind of already, we're working with the patient and the families, and it's all one unit. And I think with adults, it can be a little bit more cut and dry maybe, but with children, it's just a different ball game. And you really gotta love what you do when you're working with kids, which I do, because you'll see that that's, it's with all the disciplines here anyway, that's kind of how it works. I can't speak for social work, for example, but my guess and my experience with MD clinics is they only go once in a while. It could be every 3 months, 6 months, a year. So the bonding is not always, as you're not able to nurture that relationship where when you're in outpatient, seeing them one time a week for a long time, you're able to get that bonding in. So.
Why is treating these patients through the means of OT important to you, and how has it impacted your life?
So for me, it's as an OT, I feel like treating these patients is really something that helps keep me on my toes because it's a progressive disease. Like you mentioned before, it's not just like, okay, here's 10 exercises and then you get to go home. It's really a challenge sometimes, and again, working with family members as well, because each child is so different and they go through the process so differently and they're affected differently, regardless of the same symptoms. So for me, it helps me, I feel as a therapist, to really try to think outside the box when you're helping patients. So it's not just about, let me order you equipment and then, you go home and do it. I really sit down with patients, get to know what they need and what they want and get their input. So as an OT, I feel it helps me to use all my skills, and it pushes me to learn new skills a lot of times. So that's kind of how I feel using OT for this particular diagnosis is very important, and that's kind of
that's the last thing. So I guess to close it off with something, or if you have any input on just what should more people know about DMD? Why is it important that we research and understand it?
I think if with people working with or who may be interested in working with kids with DMD, it's going to be important to really, do your homework and learn the basics about the disease, but also just to be open-minded, really look at the patient in their entirety. So it's not just about the disease, it's about who the person is, who's involved in their life, what team is working with them, and just try to continue to think outside of the box when you're working with these patients, because again, everyone's different. Everybody's going through different things, different family things, and so it would be, I think, a really good thing to have, and not be afraid to ask for help if you ever do work with these patients, and just get more information as much as possible.
All right, that's pretty much all the questions I have, so
Okay.
thank you very much for sharing with us. Thank you so
of
much,
course.
appreciate it.
Yeah, of
Thank
course.
you.
Thanks. Sorry.
As you have listened to Ms. Rivero, we have learned that occupational therapists work with DMD patients in many aspects. She has worked with them on everything from self-care, maintaining strength and development, to fine motor, visual processing, and other sensory work. Occupational therapists serve as a guide for the patients as the once young and playful boys grow up and begin to develop fears, questions, and concerns about this disease. Ms. Rivera has worked alongside different people also involved with the lives of DMD patients, including social workers, doctors, and people in the school district to cater to the needs of each individual patient. The patient's family also plays a big role, as they need to undergo parental education to understand equipment, safety in the home, and how to modify their activities to preserve their muscle function. Working with DMD patients requires a case-by-case analysis, as there are no blueprints when working with these young boys. Everyone and every body is different, and occupational therapists work to make sure that the needs of the patient are taken care of and to enhance their quality of life.